We're going to welcome Greg Schroeder up to talk about complications. Thank you.
All right, I'm glad that nobody's in the room yet because they won't have to hear my see the disasters and horrors that you are all going to come across. Here are my disclosures. Realistically, none of these are relevant to anything that I'm going to talk about today. I mean, this is the first 3 slides of this are probably the most important slides of the entire talk, and there's not many people here. The first thing is you cannot bury your head in the sand when you have a complication, right? I mean, I think the most important thing for the residents, fellows, junior faculty is bad things happen. The way that things get really bad is when you pretend like they're not happening, right? You have to be a complete neurotic psychopath when it comes to complications to be a good spine surgeon. That's just the truth, right? And it's hard, but you have to be on top of it. And if you're burying your head in the sand, something bad is going to happen, right? Spine surgery is hard. Chris Kepler loves to say spine surgery sucks, right? You can do everything you want to do. It can go right, and the person still has a complication, and you have no frickin' idea why. So bad things happen. You got to keep your head up. You know, the previous group talked a lot about this. Man, you got to lean on your partners, your colleagues, your mentors, whoever it is, right? I mean, I will constantly email one of my partners or call them and say, hey, look at these films, and be like, this is what, you know, particularly if I'm thinking about not being wildly aggressive, I'll call them and make sure that they don't think I'm burying my head in the sand. I'll actually say that to them. I was like, look at this, make sure that you don't think I'm ignoring what is a real problem, because I'm always concerned about ignoring a real problem. All right, so here are other things when you're talking about dealing with complications, right? You start your first year out in practice, things aren't going very well, you're having a drink or two, you got to figure out how to manage yourself, and this isn't the answer, right? I mean, all of a sudden you're having, you know, 2 cocktails a night because you're stressed out, you're fat, you're not sleeping well, you don't feel good. Guess what? That just makes everything worse. So I'm not saying that I know all of the right answers, but trust me, I mean, I've been through this. That's not really solving anything. Not that this is perfect, right? But we got to figure out how to manage our stress when it comes to complications. Wildly better to manage your stress exercising than it is managing your stress with booze, okay? It's productive, you're done, you get up the next day and you feel good about yourself as opposed to having a headache. So just think about it, how to do it. All right, durotomies. You cannot be a spine surgeon if you are afraid of a durotomy, right? I did residency and I had one attending, God bless him, who literally used like a 1 millimeter kerosene doing like a TLIF, and it was like a 6-hour 1-level TLIF. He didn't ever get a durotomy, but my God, it was painful. And I cannot envision what his infection rate was, right? So these are gonna happen, so you just have to be honest about it, right? These are the only 2 slides that I'm gonna give that talk about actual evidence as opposed to just how I deal with complications, right? When you talk about flat bed rest is a bad idea, okay? People who are on flat bed rest for long periods of time get complications, right? If you're an orthopod, you know this from people who have hip fractures and you say you want to get them mobilized, right? We looked at this, 24 hours of bed rest, more than 24 hours of bed rest, like wildly increased the rate of medical complications if you kept them down. There's people who talk about like not putting in a drain, right? Okay, you can put in a drain in a durotomy. We did one where we looked at it, we had 113 patients who had a drain that put out less than 40, 66 that had a drain that put out more than 40 when we pulled it. Guess what? They all did fine, right? So putting a drain in is not a problem. The old like notion that you need to put somebody on flat bed rest and not no drain and like leave them laying there for days is a bad idea. Okay, so how do I deal with it? Well, listen, if I always try to get a perfect repair, right? If it is possible, you should sew it shut, right? I use 6.0 Gore-Tex, whatever you prefer, but 6.0 Gore-Tex I think is good. I also think that if you're doing it through a tube or a tailor or something minimally invasive, there is something called the Durastat. My partner invented it. I have no use with it. It costs about 10 times as much as a 6.0 Gore-Tex, so don't use it routinely, but sometimes through a tube that can be helpful. I do think you try to sew it, then I cover it with blue goo. DuraGen, DuraSeal, do the whole thing, right? But then I get up and walk. I actually tell the residents not to tell anybody that they had a dural tear, because if you tell them they had a dural tear, the nursing staff or the overnight resident is going to be like, oh my God, he complained his eye is twitching. It's got to be that he had a dural tear. Lay him flat. So I don't tell anybody that. I put in, if I get a perfect repair, if I think they need a drain for other reasons, I put it in. If I don't think they need it, I don't care. I still, like, if I get a dural tear on a microdisc and I fix it, I still send them home. I used to keep them all in the hospital. I just kept them in the hospital for an extra day, and then I sent them home. Like, it didn't make any sense. So now if I get a great repair, I send them home. What I do is I lengthen each incision. I think the most important thing that you possibly do with dural tears is the fascia. Lengthen each incision by a ½ inch on each side. I do interrupted #1 vicryls, and then I do a Stratafix that I run back and forth so the fascia is perfect. Then I do vertical mattress nylons that you don't crank too much, right? If you have a vertical mattress, nylon stitches, if you do it well, the skin epithelializes in like 48 hours. It's about the fastest one you can get. So as opposed to monocryl or something else, I think that makes sense. And I just get them moving. That's lumbar. My biggest comment about cervical dural tears is don't do OPLL from the front. And you won't get that many cervical dural tears, right? I mean, so this was a patient that I had that had OPLL. It doesn't look like he has that big of a bone spur in the front on this x-ray, but it was pretty big. He insisted he had swallowing problems. I always send people to ENT to tell them that it's not coming from the bone spur. ENT said it is coming from the bone spur. You have to take it off. I was like, that's crazy. So we did it. It went great, but this was the actual footage in the OR. There was CSF everywhere. Did a corpectomy, a 1-level ACDF, backed him up in the back. I thought things went great. He did have a little bit of a C5 palsy, so I'll get into this in my epidural hematomas neurodeficit part, but get an MRI if you have a neurodeficit. You get a CT scan and an MRI, and you check all of your work every time, no matter what, just do it. So we got it. I thought, all right, it looks pretty good. There's not like CSF everywhere. We're gonna be fine. I left the drain in for 3 days, took it out, kept him there for another 24 hours, made sure nothing was going on. I thought, all right, we missed it. We dodged a bullet here. Day 14, he calls my neck, feels like his neck is super swollen, send him to the ER. He's got CSF everywhere, so what do? Neurosurgery puts a lumbar drain in. The plan for them was they thought, oh, we'll put a drain in, it'll be fine. After about day 3, he starts coughing everywhere. His neck feels like he's big. Of course, this is how complications always work. I'm in fucking Rio, sorry. I talked to the neurosurgeons. He thinks it's stable. We're gonna take him to the OR next week. So Harrop and I took him to the OR next week. Got real fancy. We like quote unquote mobilized the longus colli. That means we cut the longus colli and moved him over and sprayed a bunch of blue goo on it. Then they put a lumbar drain in for 5 days. We discharged him without incident. It healed up. But my biggest take home was just don't do OPLL from the front. Infections, right? I think when we think about infections, unfortunately we are all gonna get infections, and this is one of my partner's cases, looks great. This is what the wound looked like. Okay, this is easy, right? I mean, if you have somebody who has a lot of pus draining out of the wound, you open it up, you wash it out, you get ID involved. If the fascia looks terrible, you wash it out 2 or 3 times, and then you close it. That's the simple one. The question that there's not really any literature for, but that I'm going to talk to you guys about is, what do you do with the like 67-year-old that's diabetic and their hemoglobin A1C is 7.2, and they're in your office and their wound is 2 weeks out and it's like kind of minorly draining, but it doesn't look infected? Like, how do you deal with that one? I don't think there is any like real evidence-based way to do it, but so here's what I have done that has worked for me, right? I know from our kind of ID department that if they have, MSSA or MS or MRSA, for the most part, if it's community acquired, it's susceptible to Bactrim. It's not susceptible to anything else. I put them on oral Bactrim for a week. I get ESR and CRP. Oftentimes it's elevated the first time, but then I see them back in my clinic a week later with a second set of ESR and CRP. If it's trending down or it's normalized, then I feel pretty confident. Oftentimes I'll keep trending it if it is not kind of completely normalized. But if it's trending up after a week or the wound still doesn't look good, just take them back and wash them out, right? it's hard. You don't want to be irritated with, like, gee, I'm taking so many people back. But right, if you have somebody who you have a questionable infection and their lab work is not headed in the right direction, right, it's fine for it to be elevated a week or two, but it should be headed in the right direction. If it's headed in the wrong direction, if you just ignore it, you're going to end up with a picture like this. So you want to just be aggressive early, wash out more people than you think need to be washed out, and if you do that, you won't have any kind of major issues. All right, hematoma, neurodeficit. I put these together because I think realistically, from a timing standpoint, right, we don't have time to talk about every complication, but most complications that really happen are really post-operative neurodeficits, right? If you're doing neuromonitoring, obviously everybody hurts people in spine surgery. It does happen. But the big one that we think about when we think about a neurodeficit is usually a hematoma. This was a very nice, like 75-year-old lady with myelopathy. Did a PCF on her. She did great. I saw her post-op day 1. She looked great. Post-op day 2, she had a C5 palsy. Fellows didn't tell me. I didn't see her. They're like, oh, everything is fine. We just thought she had a C5 palsy. Even if it's a C5 palsy, just do the appropriate workup, right? Do the imaging. Get an MRI and a CT scan, because sometimes a C5 palsy is the canary in the coal mine, right? They call me like the next day, it's 2 in the morning, and the person is out. They are completely out. So they now have they had a hematoma that the fellows and the resident picked up the day before and wrote down that she was like a 4 pre-op, and she was all of a sudden a 1 in her deltoid. Fortunately, we took her back, we washed her out, and it got better, and she now walks into my office. So, but the moral of the story is, right, you need to have a very low threshold for imaging people, right? It stinks. If you image somebody, I'm going to tell you, 80% of the time you're taking them back because there is some kind of fluid collection. It's almost always there. But if somebody has a neurologic deficit, most commonly, if you did something in the OR, right? Most commonly, the reason for it is either a post-op hematoma, seroma. Evaluate it, identify it, take them back right away. Just wash it out. It doesn't matter if there's a drain in. Drains don't really help. I don't think last time we talked to Utah didn't put drains in anybody. We put drains in everybody. Still get them. It is what it is. You're a spine surgeon. If they have a neurologic deficit, CT scan, look at your screws. MRI, look at your neurodeficit, or look at the surgical bed and wash them out right away. All right, so conclusion. I think mental toughness, right? Unfortunately, this is hard, right? Remember, this is a 30 to 40 year practice. This is not a 1 or a 2 year practice. So you got to think about it. Think about ways to keep yourself strong. Lean on your mentors. And when it comes to complications, be aggressive with minor complications so they don't turn into major complications. If we had MRI'd that lady when she had a C5 palsy, we would have washed her out when she had a C5 palsy, and she would never have been paralyzed. All right, thank you.